Now we'll switch to John Oudyk, our occupational hygienist from OHCOW's Hamilton Clinic, and his partner in investigation, I wouldn't say crime, Peter Smith from the Institute for Work and Health. And they are going to do their presentation on some preliminary results on the worker pandemic experience survey, so we can understand what's happening with workers across the province and the country. So, John, I think Tony will have switched to you. Great. And we've turned off the videos now, just to make the sound quality better. I hope everyone, I know Ron was a little bit soft, but hopefully everybody could hear him okay.
Okay.
Yep, we can hear you. Thank you, John.
Okay. This is preliminary results for a pandemic survey for workers that do not work in the healthcare sector, and Peter Smith and I are presenting today. We're also on behalf of an ad hoc survey group that got together and started these surveys. So a bit of the background. We started to get involved in this area with healthcare unions who were responding to some draft infection control procedures put out by Public Health Ontario and Public Health Agency of Canada. And based on previous work that we'd done on SARS and H1N1 and Ebola, we had established a relationship with these unions. And we were also looking at some of the literature out of China, which noted a number of surveys characterizing the mental health experience of healthcare workers there. So we floated the idea with the healthcare unions and with the CFNU and created this ad hoc team to set up this survey. Now, originally, we got together with the healthcare unions and made a healthcare survey. And these were the people involved. It's a number of health and safety staff reps from unions in Ontario, also the Canadian Federation of Nurses Unions, the Ontario Federation of Labour, and a couple unions also in BC. Guy Potter, who's an occupational psychologist with Duke University Hospital in North Carolina, and is also connected with the Copenhagen Psychosocial Questionnaire International Network, was also involved, and as we mentioned, Peter Smith, and a variety of other academics and activists from Canada and the US, and also a couple of us from OHCOW. So based on the healthcare survey, people started thinking, well, let's also look at non-healthcare workers. So Dorothy Wigmore, Laura Lazansky, and Alec Farquhar volunteered to adapt the healthcare workers to the non-healthcare work environment. And we ran it also past the same group. And it's similar to the healthcare survey in that it was designed to capture worker experiences during the pandemic. It takes about 15 to 20 minutes to fill out the 70 or so questions. And it also allowed respondents to create an ID code so they could fill out the survey more than once. Conditions are constantly changing, so we had thought at one time that workers might be interested in noting some of these changes by filling it out more than once. It's available in English and French, and we want to thank OHCOW and the steelworkers for translating, and also Claude Letier from Laval for checking the original translation. And by the way, it's still available online at these links. The survey content, we used some of the COPSUC questions, which are in stress assess to measure burnout and sleep symptoms. We also used recognized scales to measure anxiety and depression symptoms. We also used a self-efficacy scale. We made our own exposure questions based on a lot of the information the unions were giving us from their members' experience about the adequacy and availability of personal protective equipment, and also preventive measures and procedures or infection control programs and training. The scales that we use from COPSOC to measure psychosocial aspects of work included quantitative demands, work pace, predictability, role conflict, supervisor support, colleague support, and we created a new question on family support. And finally, we asked a question about the health and safety climate, the psychological health and safety climate. As of May 13th, we've had 4,888 people open the survey and complete at least one question. However, not everyone filled the majority of the question out. So we counted over 3,000 respondents who filled at least 70% of the survey out, and these were the ones that we analyzed. And it came in waves. The first wave was at the end of April, beginning of May, and then in the first week of May, we had another wave. Recently, it's been very slow. Responses by union, here you can see OHCOW made up over a third, another 17% from Unifor, almost 8% from QP, and there were many other unions making up another quarter. The responses by province, Ontario is the bulk of it, and a few of the other provinces. The healthcare one had more response from other provinces, but this is primarily Ontario. Age distribution is fairly typical of working populations. Identity, over half of the respondents were female, about a third were male, and then we have the other identities. Current working status, about just over half were working at a workplace. 40% were working at home, and 6.7 were not working now, but had been working as of the beginning of March. So they essentially have been laid off because of the pandemic. We asked the question whether people, we asked people to rate how the different parties were doing protecting workers and others on the job. And we broke it down by union, employer, government, and health and safety committee. And for those who are actually working at a workplace, you can see that 58.5% agreed or strongly agreed that the union was doing a good job at doing their best to protect workers. Employers were 44.4%, the government was 52.6%, and the health and safety committee in the workplace was 48.5%. When it came to people who were working remotely, it was quite interesting that for unions, employers, and the government, they were much more positive than those who were working at a workplace. 76 and 75.5% for union and employer. Government 70.5%, and the health and safety committee about the same as for those who are working at a workplace. We asked how much contact do you have at work with coworkers and members of the public? So we were thinking infection control is about preventing contacts. So 20% either said they had contact with either coworkers or public. 61% were within 6 feet of a coworker, or 46% within 6 feet of public. You note they could check more than one option here. And 10% said they had no contact with coworkers or no contact, 24% no contact with the public. So how many workers in your workplace have COVID? 48% said none, 22% said one or more. This was rather interesting. There were some healthcare workers who responded to the non-healthcare survey, so that may take up some of them. But 30% didn't know, and it's the not knowing that also contributes to fear and anxiety. How many people, not coworkers with whom you work, have COVID? 50% said none. 11% said at least one. And again, there are some healthcare workers in here. But 39%, almost 40%, didn't know whether the people they encountered while working had COVID. And finally, I want to just cover some of the basics of an infection control program as people are thinking of getting back to the workplace and using the hierarchy of controls. This was not designed to for COVID, but it can be used for infection. And here we have elimination, working at home, or telemedicine, that type of thing. Substitution, engineering controls, administrative controls, and PPE. And from here, I'll turn it over to Peter, who will continue.
Right, thank you, John. Can I just get the sharing? Yeah, I can share. I share content, is that right?
Yep. Slide 19.
Perfect. So hopefully you can see my screen now. So this is where John left us off. And so, as John had indicated, for the rest of the presentation, we want to focus on the relationship between these measures, which are part of the hierarchy of controls, in particular, thinking about PPE and infection control programs and how they're related to mental health among non-healthcare workers. So, as part of the survey, there was 18 different types of infection control procedures that we asked about. And for each of these different types, which I've listed here on the bottom of this slide, people could tell us where that type of infection control procedure was appropriate and adequately implemented, appropriate in type but inadequately implemented, if it was inappropriate, lacking, or a number of people were not sure if that required, or they said it was not applicable. And using these responses, we could make two classifications. One, we could classify workers who thought that this type of infection control procedure was needed versus those who didn't think it was needed. And then among those who thought it was needed, we could define those who had that need met because it was appropriate and adequately implemented versus those where it wasn't being met, either because it was inadequately implemented or the actual procedure itself was lacking or inappropriate. In terms of now looking across the different types of infection control procedures, here in the grey bars, you can look at the proportion of respondents who said that type of procedure was needed. And then in the green bars, it's the proportion of people who said that need was being met. And so in looking at this slide, this is the first 9 types of infection control procedure. The green bar is the proportion of the grey bar in terms of the need being met. And you can see here there's some differences in terms of what infection control procedures people think they need. Among the highest types of needs are around training about cleaning, reporting procedures, physical barriers. And you can also see in the grey bars about whether those needs are being met or not. In terms of thinking about training about infection control and reporting, in our sample, so this is the 1,636 workers who are physically at their workplace, 45% of them have an unmet need in relation to training about infection control and reporting. Another 784, which is 48% of those workers which are currently in their physical workplace, have an unmet need around training about cleaning, the cleaning procedures they should be doing. These are the other 9 types of infection control procedures, and you can see again there's variation in terms of things that workers think are needed, such as some of the high ones are around physical distancing, both from co-workers and around clients. Again, cleaning, the disinfection of high-touch areas. And again, when we look at physical distancing from clients in the workplace, 43% of those people at work say there's an unmet need in relation to being able to physically distance themselves from clients. and 53% say that there's an unmet need in terms of being able to physically distance themselves from co-workers effectively.
Peter?
Yes, Val.
There's a little bit of, I don't know, it's hard to say, a little bit of a noise when you're talking. Are you using the headset for your phone?
I am using my headset. Is it?
It's okay. It's just, we can hear you and understand. So sorry I interrupted. Just go ahead. It's just
No, that's
a
okay.
little bit of
I've been
static
told-
kind of thing. But it's
static,
clear.
okay. I've moved my phone a bit closer to me, if that helps. It's a Bluetooth headset. But let me know if it gets worse. I've already been told I need to enunciate better by my co-worker.
I didn't say that. Okay, thanks.
No, someone else said that. He's on the line. In terms of personal protective equipment, we ask similar types of questions. So there's 10 different types of personal protective equipment. And again, people were ranked the type of PPE based on whether it was appropriate and adequate in terms of its supply, all the way down to it was needed but not available. And then we have groups of workers who say that they're not sure or they don't know what's appropriate or applicable. And again, when we look at PPE and the proportion of needs being met, we can see variation where the things that workers are saying they need the most are things around soap and water, facilities, hand sanitizer, gloves, and then we can see the proportion of those needs which are being met. And when we think about, well, we look at PPE, 36% of the sample, 593 workers, say that there's an unmet need in relation to surgical masks, and another, it's hard to see because of the way it is, for 609 or 37% of the sample, so that there's an unmet need in relation to the provision of N95 masks. In terms of describing the number or the proportion of needs which are being met, you can see there's a slightly different picture here when it comes to infection control procedures and PPE. Infection control procedures here are in the blue, with PPE being in the orange bars. In terms of 100% of the needs being met, it was more common among PPE than it was among infection control, although still only just over a third of our samples said that all their PPE needs were being met. And that, again, in relation to the other end of the scale, where we look at the inadequacy of people who have none of their needs being met, 18% of the samples, so almost a fifth of the samples, say that none of their infection control procedures are being met, whereas only 6% say that none of the PPE needs are being met. We also asked questions about training in relation to COVID-19. So we asked people to rate the adequacy of their training about working with COVID-19. They responded that it was excellent, very good, or lower. For those who said excellent and very good, we described that training as being adequate. We asked people if they felt sufficiently trained to don and doff their PPE without contaminating themselves. And for those who said that they had been trained and felt very confident, or had been trained and felt confident, we said that their training was adequate. In terms of looking at the proportion of respondents, again, those that are physically in the workplace at the moment, PPE training and adequacy was higher, although still less than a third of the sample reported that they felt confident around PPE training and adequacy, and only 16% felt adequately trained around working with COVID-19. In terms of the health outcomes, I'm going to present information on 4 different health outcomes and more detailed information on these too. So we use the Generalised Anxiety Disorder Scale, which is the 2-item scale, which is a screening scale for anxiety, which asks 2 questions, one about feeling nervous, anxious or on edge, second being about not being able to control or stop worrying. We also ask questions from the Patient Health Questionnaire, which is about a screening tool for depressive symptoms, asking people if they had little interest or pleasure in doing things, or they were feeling down, depressed or hopeless. People have responses on both these scales saying not at all. They've felt that way for several days, more than half the days or nearly every day. When you add these 2 questions together, you get a score from 0 to 6. And when people score 3 or higher on those scales, that's a standard cut point to say that these people really should be screened for anxiety or depressive disorders. We also asked people about fear, levels of fear. So on a scale of 1 to 10, how would they rate their current level of fear in relation to the pandemic? And also about concern about bringing the virus home to those who they live with or their friends, and that ranged from no concern up to 6, which was extremely concerned. In terms of the sample, thinking about the screening cut points, so for anxiety, 42% of the sample of workers, this is the entire sample, both those working it remotely, those who were at their physical workplace, and those that had been laid off or didn't have any hours in the last week. 42% of the sample had a GAD score of 3 or over, so that would mean that they should be screened for potential anxiety. In terms of depression, it was a little bit lower, but still about a third of the sample had a score of 3 or over, again meaning that they potentially should be screened for potential depressive disorder. In terms of fear, the median, which is the central point in the distribution, was about 6. You can see the upper quartile there is 7, so that's 25% of the sample had a score over 7, and 25% of the sample had a score under 4. In terms of concern, again, you can see that the scale itself has been maxed out, where more than 25% of the sample rated that as high as they could in terms of being extremely concerned about bringing the virus home to those who they live with. When we look at the proportion of people with scores of 3 or higher based on anxiety and also on depression, first of all, we could stratify it by those people who are working remotely, those that are at their physical workplace, and those that are not working. And you can see here we get a sort of a graded relationship where levels of anxiety are lowest among those who are working remotely, higher among those who are physically at the workplace, and a little bit higher still, although not statistically different, for those who are not working. Similar trends for depression as well. But it's interesting once we start breaking this down by the provision of PPE and infection control procedures at the workplace for those that are physically at their workplace. And this is that in relation to looking at anxiety here. So on the far left is the proportion working remotely, which is 38%. You can see those that are at work but have 100% of their infection control procedures being met, they actually have the lowest proportion of anxiety at the moment. So they're physically at the workplace and feeling protected. Still not a low level of anxiety, 29%, but the lowest level in terms of the groups in our sample. And those that are at work with none of their infection control procedures being met actually have the highest levels of anxiety in our sample, higher than those that have actually lost their job. So quite a difference in terms of the distribution of anxiety across those people who are at work in relation to infection control procedures. Similar pictures in terms of depression in relation to infection control procedures, same sort of relationships, the best or lowest levels of depression among those that are physically at work with their infection control procedures being met, much better than those who are working remotely. And again, the highest levels of those who are at work without any of their infection control procedures being met. Again, looking at PPE needs, we see similar relationships. Again, the worst being those who are at work without any of their PPE needs being met, and the lowest rates among those that are at work with 100% of their needs being met. And again, a similar picture for depression scores here. So in terms of key messages to leave you with for today in relation to these preliminary findings, one is there is significant amounts of stress, fear and anxiety. And this I don't think is news to anybody. Ron had spoken about it at the start of the presentation. We understand that there's high levels of fear, anxiety and depression among people, not just among healthcare workers, although these levels are higher among people who are in healthcare than those not in healthcare, but still we can see very high levels of anxiety and depression and fear and concern among people who are not in healthcare. There is a lot of variation in terms of the mental health experiences of workers who are physically at their workplace in relation to how well the infection control procedures and the PPE is being provided in terms of the workplace. The lowest levels of anxiety and depression are among those where infection control procedures and PPE are being effectively addressed, even lower than those who are working remotely. And the highest levels of anxiety and depression are among those where these needs have not been effectively addressed, and these are higher than those that have lost work hours or have lost income. So with that, I would thank you. Any questions or comments, you can use the chat box. I can see a few of them have been bumping up as I've been presenting. If people would like more information on this presentation or on the survey, they can contact John or myself. Our email addresses are just there. Thanks very much.
Thank you, Peter and John. I'm just going to try and scan through some of the questions. First of all, there was a question just around improving the participation in the survey. Can it be started and stopped? And can we make that clear? I know that people can go back and do it again, but I'm not sure that it can be started and stopped. Can it, John?
That's one of the reasons for the high numbers of people who start it and don't get very far. So if they leave the survey and come back to it, they have to start over. So no, you can't start and stop. But the idea of filling it out more than once was the fact that things are changing, and as they change, the level of anxiety and fear change, and also the controls change. So we were interested in seeing if we could follow any of these changes and encourage people to fill it out more than once. I don't think we've had a lot of people who have come back to the survey and filled it out. It's a 15-20 minute survey, so it's asking a fair bit.
Okay, thanks. And Dorothy has made a couple of comments actually in a row here about the programmatic things missing more than PPE, and then similarly with training, which gets back to your hierarchy of controls slide and comment that that there's been so much focus on PPE that people aren't paying attention to the foundational elements of exposure control, and that's being recognized in the way people are answering the questions and in the anxiety levels too, I think.
Yes, it was for the healthcare, it was the other way around. There was more anxiety associated with PPE needs not being met. But here it was the infection control program or procedures not being met. So yeah, that was interesting for us to see also.
Sorry, I just texted to the wrong information to Tony about who's next. And I think this one's more, oh, sorry, I'm skipping over and then I can't. Oh, so there was some comment around, yes, whether a separate survey for health and safety reps or health and safety professionals might be an added dimension of this. And there was also a question that earlier about gender. I guess I'm not sure if you've done any gender analysis, including the who's working from home or who lost their job. I know there's been a fair bit published recently internationally about the erosion of gender rights on all kinds of different levels, and I just wondered if any of that experience had been picked up, or that's, I think, what the question was asking.
So I can answer that a little bit, Val. So we have, the analyses which I presented have been adjusted for whether someone's male or female and a visible minority. We do see in those models that levels of anxiety and depression are about 10% higher among women compared to men. We haven't done any stratified analyses just yet, and there is limited information in this particular survey around roles in the home for those who are working remotely, but we understand that that's certainly an important issue that needs to be further explored.
And then also comments around the IRS and if the IRS is unhealthy. So not sure that it's a question more comment, just and then PPE becomes the kind of, flag that gets waved, but there's so many other issues and who's meant to be protected with PPE, sort of, not based on exposure, but on job classification, so not, on real risk. Marnie's actually saying, great data. I hope it can be published. Were there any respondents in the US?
I didn't see any. On the previous question about the we did ask a question about union roles, so I think it might be possible to go back and dig out to see if we can find the experience of health and safety committee members. So that's something we could look at.
Okay, Catherine, to ask the question about stratification by gender, anxiety and depression for workers working at home. So I don't know if we have enough of those, and that'll shift now in the upcoming, more and more people will be at work if we can generate more survey participation. And there's another question about if you can isolate anxiety from health concerns and anxiety from economic concerns.
Yeah, I mean, asking someone to, if they're feeling anxious, to sort of break it down about the levels, I think would be challenging in a short survey. I mean, although it's 20 minutes, it is a relatively short survey. I mean, I think what we're trying to do at the moment is better understand the factors in the workplace, especially modifiable factors that are associated with differences in anxiety and depression. And I mean, I think it's important to recognise that all the infection control procedures in the PPE are to some extent modifiable. And so it wouldn't be impossible to imagine everyone being in that best group, which is people back at work with 100% of their needs being met.
Okay, thanks. There's a suggestion of whether an exit question if somebody leaves early, as to why, in terms of time or distraction, that kind of thing. I'm not sure we can add something like that in SurveyMonkey, which is the tool that we use, and allowing an offline version. We do have the survey on our website. Actually, I will put those links in later, but it's not. You don't have a system of administering it then or collecting it as an emailed version and inputting it. So
in Stress Assess, we do have that option. However, when people leave, they rarely answer the question that pops up as to why you're leaving.
And this one, adequate protections show less mental health concerns from the presentation. Please comment on this result in general, unrelated to COVID. So, yeah, I guess if you, is it a common if people have PPE, they feel more protected and feel less anxious? I think is the.
I guess if we did this survey, in 2 or 3 years, we might be able to know the answer, but we can't go back prior.
Yeah.
I do think, I mean, in general, I guess if you think about being able to protect yourself from the hazards that you're exposed to in the workplace, always would be better than being unable to protect yourself. And you would imagine, I mean, we've seen it in general surveys where we've looked at our definition of occupational safety vulnerability, which is about hazards and inadequate protections, and those that have hazards, regardless of the hazard, with inadequate protections, are much more worried getting injured at work and have more mental health problems.
Peter, would your work with vulnerability answer this question?
Well, I think it draws to some of that. I think in general, this is a situation, if you want to think about it broadly, that we've got new hazards in the workplace and we need to think about ways to adequately protect workers from those hazards. And I think, if you could even extend this to those who are working remotely. I think there's a new set of hazards for those workers as well, and understanding what those hazards are and how to protect workers would probably improve mental health in that context as well.
Well, just as we're seeing that, the default that people see is protective equipment. So it's more tangible, I guess, than all the other controls that that health and safety professionals recognize are there all the time and therefore more protective. But you can see how people would make that connection. Okay, I think we should go further. I did get an answer from Ron's office, and I am putting in the chat box some of the links that he mentioned.